So transmission and prevention of hepatitis B infection. We know that mothers are universally screened for Hep B and have been for, I don't know how many years. We know that now you get a dose of both vaccine if your mother's positive, but also immunoglobulin within the first 12 hours of birth, and ideally within an hour of the mother giving birth. We do know, however, that the transmission from the mother to the child is higher depending on the viral load of the mother, and that's probably the biggest single variable in terms of the rates of transmission. Just to sort of frame that a little bit, if your mother has a very high viral load and you have no immunoglobulin and no vaccine, the risk of transmission from mother to child is something like 70%, so very high rates of transmission. If you give immunoglobulin and vaccine at birth, you bring that risk down under 10%. So pretty significant drop. There's also more work now around treating mothers in pregnancy to bring the viral load down to, again, reduce the transmission. And if you bring the viral load down in pregnancy before the birth, then you give immunoglobulin and you give vaccine, your risk of transmission is down in the sort of 1% region from mother to child. So we can make a really significant difference if you say that the sort of unaffected rate in someone with a high viral load is 70%, and we can get that down towards 1% with the interventions that we can take. Doing a cesarean section is not protective, and there's no increased risk with breastfeeding. And really, if you think about it, if you give immunoglobulin and vaccine at birth, you've got immunity from that point on. Breastfeeding really shouldn't be a risk factor to increase your transmission. And if you do all those interventions at birth and you get your risk of transmission down towards 1%, then the breastfeeding doesn't add significantly any additional risk to that. Sexually acquired, it's a lack of barrier protection. And I think it's always something that, we've got those sort of two discussions. You're much better at than I am in terms of discussing with patients around the sexual transmission, but you've got the use of contraception and then the use of barriers to prevent STIs. And we know that clearly in our head that there's two different reasons to use condoms, but sometimes patients are not so clear as to why they're using one and the other, and do forget that using a condom is, of course, acts as a prevention for STIs. And then other things less common. I mean, we counsel people who've got hepatitis B not to share toothbrushes, not to share razors, because you can get a small amount of blood on it. And we counsel people not to do home tattoos and that sort of thing. We're well aware that the risk, if you go to a registered tattoo parlour in Melbourne, your risk of getting a bloodborne virus is incredibly low, and they're all very well run. If you get a tattoo in prison, or if you get a tattoo in your back shed when you've had a few beers, then the risk is significantly higher. And then again, this sort of makes it onto the list because we're doctors and we like to have all the things on the list, but blood transfusions, it's less than 1 in a million your risk of acquisition from a blood transfusion, because there's now pooled, so blood units get pooled and then a PCR gets done on that, so you're looking for the actual presence of virus. Surgery, dentistry, again, very low rates. Really, the examples, and this is a hepatitis C example, not a hepatitis B example, but as like that situation where the anaesthetist wasn't engaged in the proper infection control procedures, and hence people became infected. But really, if people take the proper procedures, the risk is incredibly low. Hemodialysis, there is a small rate, even I guess you're using large bore needles and a high volume of blood routinely. So there is a very small risk, even with all of the correct procedures. And people who are on dialysis often lose their immunity. So hence, even though everyone who's on dialysis should be vaccinated against hepatitis B, they sometimes lose immunity. Risk of Hep B exposure to various blood fluids, moderate to high. We know blood, serum, wound exudates, serum, vaginal fluid, and saliva. Look, I think that saliva really, to be put on the moderate to high list, is concerning to people, because I very much, when I see patients, like to say, look, these things do cause you risk and these things don't cause you risk, because I think there's enough stigma attached already to things without saying that kissing, cuddling, you need to clearly say kissing, cuddling, sharing cutlery, sharing crockery, sharing toilets, sharing bathrooms is not a risk I mean, we do suggest that household contacts are vaccinated, but the risk is low to zero in those settings. And I think we sometimes sometimes we sort of put these things on a list because we have examples of transmission where we don't really have any other risk factor, and particularly in young kids, sometimes it's not exactly clear how transmissions occurred, but the risk is very low. So, who should we screen for Hep B? And it probably follows from what we've just been talking about. So, people born in, basically people who are born outside Australia and not in either Northern Europe or South America. Really, if you break that down into those lists of where you do screen for it, basically anyone who's born in any of those parts. There's low rates in South America and low rates in Northern Europe, but other than that, rates would meet the barrier for screening. Sexual and household contacts of someone who has hepatitis B, and you should vaccinate those who may be susceptible. As you're probably aware, the Victorian State Government funds vaccinate. The State Government or Federal Government funds that? I think it's the State. Funded.
Yeah.
There's some vaccine funding comes out of the state and some vaccine comes out of the federal, I'm not sure. So,
no, I'm not.
Pregnant women, we know we screen. Men who have sex with men, people who inject drugs, commercial sex workers, hemodialysis patients, people living with another bloodborne virus, so Hep C or HIV, or diagnosed with an STI. Similarly, if you've got one STI, you're at risk of getting another STI. In anybody prior to receiving significant immunosuppressive therapy. Now, that's not everyone who's going on to 10 milligrams of prednisone necessarily needs a Hep B screening, but anyone who's going on to high-dose immunosuppression, and one guideline is more than 20 milligrams for more than 2 weeks of prednisone, and how does that tie into all your other biologics and other agents? It's a bit hard to say, but basically people who are going on to chemotherapy, significant immunosuppression should be checked for hepatitis B. And I think that sort of takes us back to another story, which I won't talk about too much tonight, but is again one of the more interesting bits of hepatitis B, is that you never totally get rid of hepatitis B. So earlier I said we've got 200,000 people in Australia who are surface antigen positive, and 2 million people who've got hepatitis, who were exposed to hepatitis B. Those people still have an amount of the Hep B DNA incorporated into the cccDNA within their hepatocytes. So if you significantly immunosuppress those people enough, it can reactivate. So the person who's gone from surface antigen positive to surface antibody positive, surface antigen negative now, if you give them enough immunosuppression, you can potentially reactivate hepatitis B that's incorporated into the hepatocytes. Now that's sort of, for you as GPs practicing, that's less relevant, but for, if you're a physician practicing at Peter Mac, giving people high-dose immunosuppression, if they were surface antibody positive from past infection, not surface antibody positive from vaccine, surface antibody positive from past infection, you have to keep an eye on that because it can actually drop off with significant immunosuppression. As I said, again, it's not low-dose, small amounts of immunosuppression, it's significant immunosuppression. So when we say we cure hepatitis B, we fully control it, we have total immune control, but it is still there incorporated into the hepatocytes. And if we find up hepatocytes and do PCR on the DNA, we can find elements of the DNA of Hep B that can potentially reactivate in significant immunosuppression. That's not a major issue, but it is interesting. People at risk should know their hepatitis B status. There's probably been some myths around Medicare and payment, and this sort of myth that if you put on the form query chronic hepatitis B, you can order the 3 tests that you really need to know, which is surface antigen, surface antibody, and core antibody, which will tell you whether someone's immune, whether someone has had it in the past, i.e. I just talked about exactly what that means, or whether someone currently has hepatitis B. And it doesn't contravene Medicare screening provisions. So I guess we and those at GPB would like to hear from people if you start hearing that story and getting chased up and so forth. Not testing high-risk patients equals a missed opportunity. We know that, as we said, something like 15 to 25% of people, if untreated and unmanaged, can go on to die from their hepatitis B. So it's something that we want to intervene, follow through with. And then the secondary story with that, of course, is about screening and vaccinating the contacts. And that's really just the specific piece of information around the Medicare billing, and just so that you can request those tests in someone who you're concerned about. So a little bit about vaccination. There's, as I said, universal vaccination in infants since about 2000, and that's achieved something like 95% coverage. So you should be able to say that someone who's vaccinated, someone who's born since 2000, who's had their vaccinations, highly unlikely that they'll get Hep B. Not impossible. And the caveat to that is if their mother had hepatitis B at the time they were born and they were given the vaccination, as we said, it works, but it doesn't always work. So there is a potential that they've had Hep B, that they still get hepatitis B. Those risks are very low. There's also been catch-up vaccination for those children who were aged 0 to 13 in 2000, so that goes back to kids born in about 1987. Well, they're not kids, are they? Probably GPs. Who have potentially had hepatitis B vaccination. However, the catch-up program in high schools didn't achieve the uptake of the at-birth vaccine. So the uptake rate's more like 50% in that sort of catch-up group. So I guess you'd say the born 1987 to 2000 group, roughly. Vaccines free for household and sexual contacts. And I think you can use a fairly broad definition of household contacts. And I think that, no one has any concerns with using a broad definition of what might be a household contact if you think that someone needs to be vaccinated for hepatitis B. People living with HIV and Hep C should be vaccinated. That's also funded by the Victorian State Government. People who inject drugs, again, it's funded. And men who have sex with men, again, that's funded as well. So really, if you think that someone should be vaccinated, there's a potential that that vaccine will be funded. Still, if someone sort of is going on a holiday overseas, and that's your reason to vaccinate, strictly speaking, that's not funded through various vaccine schedules or various funding mechanisms. What do I want to go through? So you probably know the schedule around the Hep B vaccination. If you've had 3 vaccinations, then if you're not a healthcare worker and so forth, you don't need to be testing to see whether the vaccines worked and so forth. We don't routinely do that in kids. They have their course of vaccine at birth. We assume that is effective, and we know that it is effective in something like 95% of cases. Even those who it's not effective probably have some amnestic B-cell response if they're exposed to hepatitis B as well. So even though their surface antibody titer might have gone down, if you expose them to hepatitis B, they still have a B-cell response. So they probably don't have as good a protection as someone who has a surface antibody titer that's elevated, but they still have some protection. And if they're not responding to vaccine, as I said, it's worth testing to see whether they're core antibody positive, and whether the reason they're not responding is because they actually have hepatitis B, particularly in that group who may have been given some interventions at birth, but maybe not all the interventions, or even they were given all the interventions and they still contracted hepatitis B at the time of birth. If you're a non-responder to a primary vaccine course, you should be given a 4th dose or a further 3 doses at monthly intervals. There's a bit of variability around that. If you've had 2 full courses of hepatitis B vaccine and you still haven't got an immune response as measurable by a surface antibody level of above 10, then there's not a lot of value in pushing on to further and further and further courses. So sometimes you'll have a further course if your immune system's been completely wiped out for whatever reason. You had a bone marrow transplant, you wiped out your immune system, then you might give another course down the track and so forth. But generally speaking, if you've had 2 courses, you've not had a surface antibody response, there's not much point giving additional courses beyond that. And so those people should be told that if they have a risk, then they should be given Hep B immunoglobulin at that time and that's particularly relevant to healthcare workers, to us. If you're one of the, I can't quite what the percentage, but it'd be something like 1% of people who are given 2 courses of vaccination still won't mount a surface antibody titer. If you had a significant exposure, you should get immunoglobulin. Now, hepatitis B vaccination is very good at reducing the rates of acute infections, and you can see there the top graph is acute infections. You can see the sort of with and without vaccination that commenced around 2000. You can see a significant drop in acute infections. But if you look at the y-axis there, you can see the number, and then you go down to chronic infections, and the number on the y-axis is a factor of 5, I think, and you can see it makes very little difference to the number of chronic infections that are in the Victorian community or in the Australian community, and that again relates to immigration. Where in Australia, we have an immigration of about 200,000 people per year. The majority of those people come from a country that would meet the criteria for at least a moderate risk. Sorry about that. Rhinorrhea. So just some key points. Most Hep B worldwide is acquired at birth or in early childhood. Most acute Hep B is due to sexual or IV drug use. Most chronic hepatitis B is due to infection at birth because, as we said, that story, you get Hep B acutely as an adult, your risk of going on to chronicity is about 5%. You get Hep B at birth, your risk of going on to chronicity is something like 90%. It's a huge difference. Key points, we know that people living with chronic hepatitis B are from particular countries. Indigenous Australians should be screened. There's a strong link between liver cancer and chronic hepatitis B, and there's increasing both incidence and mortality from liver cancer in Australia. So GPs, you're at the forefront of preventative activities, preventative and treatment activities to reduce that. Yeah.
Was most of the 200,000 immigrants through the
No, not necessarily. So, yeah, so the question was what testing happens for visa in terms of visa applications and so forth. So Hep B is not a part of most routine visa applications. People have a chest X-ray to looking for TB, and basically if you've got TB that has to be treated before you come here. If you've got latent infection then you get a health undertaking to follow up here. People have HIV testing, which is not an absolute exclusion criteria but pretty close to it. We only get a very small number of immigrants who are HIV positive, but beyond that there's no other routine screening. And I guess given most people are keen not to, there's a perception that they may prejudice their visa application if they get that testing or disclose that testing. The majority of people don't disclose that information as part of their immigration. There's some talk, I mean, there's various arguments around why that's a key opportunity missed to screen people, but I think at the moment, given the concerns and people very much when they're migrating not wanting to prejudice their cases, I think we're probably going to be left with the situation that we have currently. Interestingly, other countries have actually shifted the other way. The US now is not doing HIV testing routinely as part of immigration, which is something that we still are doing. So just about testing. So I think with any testing, we should be letting the patients know what we're testing them for. Now, you refine your description, you know, whether that's a full blood count or a liver function test or a HIV test. But a Hep B serology, a Hep C serology, they have significant consequences for people in terms of health insurance, in terms of your interactions with your partner. And once you're screening for a condition that requires you to discuss your sexual behaviours with your partner, then people really should be told what the test is, what the significance is, why you think it's a good idea to test them, but also that there is a consequence, if you like, mostly a beneficial consequence in that we think you'd potentially get effectively managed for your hepatitis B and not die from liver cancer, but also a consequence to your relationships and so forth. And I'm sure you have, and I have also seen patients where the discussion around people whose health knowledge is not as sophisticated, and the discussion of where did you get this infection that is potentially sexually transmitted has led to relationships going into disrepair. Now, that might have been heading that way anyway, but I think it's something that's important to discuss. And very much given the patient cohort that we have, the use of interpreters is crucial. So you look at the risk groups that we just discussed, and a large number of those don't speak English well. And you know about accessing the telephone interpreting service through SIS. If you're at any Medicare bill consultations, you can use TIS for free. You just phone them up, and in most languages you get an interpreter pretty quickly you really should be doing that. It's not appropriate to be using family members, particularly when you're having consent issues around STIs and so forth. I mean, I think family members are reasonable if you're just saying, well, you've got to come back at this time in 2 weeks' time for your next appointment. That's reasonable. But when you're discussing a sexually transmitted infection, using a family member as an interpreter is not appropriate. And I think basically it's fairly as simple as that. The patient needs to know what you're testing, why you're doing it, and that there is some consequence of that test being done. And I think we don't do that well. I think in hospitals in particular we don't do that well. And it's interesting how there's a strong idea that with HIV we should consent people before we do the tests. Hep B and Hep C have similar consequences in terms of the follow-through, but we don't often do that.
And how about sometimes patient has unexpectedly high AST and ALT, and just before actually just the blood sample was discussed, I sometimes bring the laboratory and then arrange some hepatitis B and C through the telephone without patient consent.
Yeah, you do that, and many other people do that as well.
Yeah.
I think that if that can potentially have consequences, and the patient would, if most patients would be pleased that they were told that they had a disease that they otherwise wouldn't have found out about. But if a patient took it the other way and said, I didn't want to know that information for whatever reason, and that information's now there, you would be much better to consent the patient to some degree to do that test. I think you're not alone in that behaviour that you're doing. I think many other people do that, but I really think that we should be, and it's not a written down consent form, sign the form process. It's not an aim to increase bureaucracy. It's an aim to increase empowerment of patients. And then I think hence, if you do get a positive diagnosis, then people are more ready to take on the information that you've given them. And I think if positive, then you need to explain, what that means. Is it acute? Is it chronic? And a lot of that goes around people sort of go, well, how did I make it to 40 years old and have this infection and I've never been sick and no one's ever told me about it, and have a sense that it must be acute, when in a vast number of people it's not acute, it's chronic, and they may well have had it all their life or at the time of birth. And then really, if you were the sexual partners or the mother or the father, or particularly the mother of that person, it would be ideal that they would test it as well. And any kids that they've had in that time when they may have potentially been infected are also tested. So it quickly has this, to do it well, this sort of ripple effect, which is beneficial, which really has those of us involved in the sector is what we want to see. We want to see that ripple effect occurring, but it may have some big waves, I guess, in terms of the ripple effect, and some people might not be so happy about it.
Just a comment from one of the participants listening, and he's going to point out that it also needs to be told the patients that A positive. You might want to read this to interpret it properly.
Oh yes, no, that's correct. So the point being that hepatitis B is a notifiable condition. So not only is these other consequences, but it strictly has to be notified to the health department. So it's a dual notification. The lab notifies the health department and the clinician notifies the health department because they're looking for a bit of clinical information. Now, unless you put on the form that you think it's acute, the health department basically puts the forms in a pile in the corner and counts them up at the end of the year. And there's no following up or contact tracing and so forth. It's different if it's an acute infection and the health department does do something with those. But for the 95% or so that are chronic, it's a pile in the corner and it's a counting up, and we find out which countries those are from and so forth, but there's nothing further done. Having said that, there's still that perception amongst the people, and particularly for people who are new migrants or who've just gone through a large process to get their visa to come to this country, they're very reluctant to upset the apple cart at all, and to have their name on a form that's now sitting on a desk in a health department it can be concerning to people, although it shouldn't prejudice their applications in any way, or their applications, or their, if once you've got your visa here, it can't be taken away. So the first three tests, and I'm sure that you're well on top of this, being GPs who are interested in hepatitis B. But really, the first three, if you're wanting to know about hepatitis B, is surface antigen, antibody to hep B surface, or hep B surface antibody, and hep B core antibody. Those three tests will tell you what's going on. So if you're surface antigen positive, you have infection currently. If you're surface antibody positive, you have immunity currently. And if you're core antibody positive, then you've been infected. Either you are infected now or you've been infected in the past, but you didn't get core antibody from vaccine. Vaccine doesn't stimulate your core antibody. If you do get a test that's surface antigen positive, then your next range of tests, and with consent from the patient, you can ring the lab and get them to add those things on, or generally speaking, you need to get the patient back for another bleed, is your Hep B E antigen or E antibody, which tell you the stage that the disease is in, your Hep B viral load. And look, on this slide, it's been included Hep B DNA sequencing, but we really don't do that. It's really, that's a lab test for research interest only. And I, as a clinician who manage lots of people with Hep B each week, have requested that test about once in the last 5 years. So, yeah, it probably shouldn't be on the slide because I think it can detract from the test you should be ordering. So you can put a little cross out through that on your notes if you like. So I think the first step is to order those three tests, and it's good to be specific, because if you write HBV testing or HBV serology, you can see there's all these different serologies, and it's easy for the lab to not give you exactly the test that you want. I think labs are improving in terms of giving people the test, but still, if you specifically state, of course, you're more likely to get the correct information. That's just to reiterate that point about Medicare benefits schedule, and I won't read the fine point out there and really bore you with that, but that you can order these tests and there shouldn't be a comeback for the patient. Now, in terms of resources around hepatitis B, so when you get the diagnosis of hepatitis B, now you guys are going to be all over hepatitis B and you won't need to look at the website, but ASHM, so Australian Society of HIV and Hep Medicine, I think it's asham.org, is it org? Put ASHM anyway into Google, you'll get the ASHM website, and they've got all sorts of resources around hepatitis, or HIV, hepatitis B and hepatitis C, but hepatitis B in particular. And particularly useful is they've got translated health information in about 15 languages, which can be very useful for the patient groups you've got. So it's a basic sort of double-sided A4 sheet around hepatitis B in about 13 languages. And I have used those, and I've given them to people, and then people have come back to me and said, no, that was good, it was useful, it helped me, it was something I could take home and read, or get someone else in the family to read, and so forth. Just as I guess it's a bit slanted towards, Australia, there's a bit of a slant towards IV drug use, and the vast majority of overseas patients have not had IV drug use and not had anything to do with IV drug use. So that can be a little, I usually tell them, look, don't worry about the bits about IV drug use, because it's probably not relevant to yourself.
There are resources in the back folder, so there are those links, for example, are written down in the back of the folder. You're right, Tom, asham.org. There's lots of things there in the book as well. Asham are very positive.
The other one is Hep B Help, which was designed with the help of Asham, but Ben Cowie, who's going to be presenting on Sunday, who was a big driver behind presenting that. But if you put Hep B Help into Google, you'll get that website, and I think that's more the real practical information. Now, where's your nearest source of referral, and those sort of more practical pieces of information. So both of them have very useful information, and you should be able to quickly find the stuff you need. So you've got all these tests, but really this is to run you through what happens with hepatitis B. So when you first become infected, you have surface antigen, which comes up. You also have E antigen that comes up. As your immune system controls hepatitis B, now your antibody to Hep B E antigen comes up and your antigen goes down. There's not an exact overlap. Sometimes you can get the situation where you either get them both positive or both negative, sort of in the transition period there. But pretty much one comes negative and the other one comes positive. You get an IgM to the Hep B core, which comes up. Now, like lots of IgMs, the serology is a bit hard to interpret. So if the IgM core is positive, that generally speaking means acute infection, but occasionally it can be associated with flares of chronic infection as well. So I wouldn't hang your hat on the IgM result. As you go from surface antigen positive, you can eventually become surface antibody positive as you lose surface antigen and then you gain surface antibody. Now they don't usually overlap. It'd be incredibly unlikely that you generally lose surface antigen, then you may have a period where you have absolutely actually a gap in the middle before you gain surface antibody there. So that's I guess generally what happens, and then your likelihood of progressing to surface antibody is, as we said earlier, determined by when you get the infection. If you get it early, you'll get to surface antibody maybe over a long period. It's a chronic journey, and many people won't get there at all. If you get it as an adult, 95% of people will progress through and get surface antibody within 6 months. And so that's acute Hep B with clearance, and then for chronic infection, your antibody Hep B core goes up, your surface antigen stays up, and you don't get the development of the surface antibody. Makes sense. So you've written the correct test on the form, specifically stated, and then you get your results back. And of course, you guys will be all over interpreting this if you're not already. But I know it is a sort of thing that you have to go through quite a few times before it really sinks in, and then it becomes second nature. So, do we want to run through those individually, bit by bit? How do you feel about that? You sort of feel like you're confident with that and how to interpret the bits of serology? We've got some case.
The card inside of everyone.
Oh, good. Yeah. Yeah. You've got some case studies coming up too, so you will we'll see if you really do know it or not. Yeah. Okay, yeah, here we go. So what's the first one? Oh, have you got it on your print? So the first serology pattern is someone who's susceptible. Obviously, they're negative to everything. So if they're in a risk group, they should be vaccinated. Anti-corp, antibody positive, anti-surface antibody positive. They've got resolved Hep B infection, so they're immune to hepatitis B from having had hepatitis B. And as that little caveat I explained, they haven't absolutely totally got rid of it, but for all intents and purposes they have. Surface antigen negative, core antibody negative, and surface antibody positive, so they're someone who's been effectively vaccinated. Surface antigen positive, anti-core antibody positive. As I said earlier, they can be a bit dubious, but usually if anti-core body antibody is positive, then they've got acute Hep B. The next range there is IgM anti-core antibody negative, so chronic hepatitis B. And then finally, surface. So this is an interesting serology, and actually it's the serology pattern of a lot of people. So often we don't actually uncover this serology pattern because traditionally, and not necessarily correctly, people have done two serologies for hepatitis B. They've done surface antigen and surface antibody and not done the core antibody. So if you did surface antigen and surface antibody, they were both negative. You just say this person doesn't have hepatitis B. But if you do the core antibody as well, and that's positive, then there's a number of possibilities, but most likely they've had hepatitis B in the past. And in fact, they can have a low level of virus present at the moment. So that's why it's good to do those three tests. And if your vaccine's not working, it generally speaking won't work to improve your surface antibody if your core antibody positive. Basically, that person has been given the best vaccine of all, i.e. the virus, and has not developed immunity to the virus. So it's very unlikely that they will develop a surface antibody titer that's elevated in the setting of being given the vaccine.
Is it worthwhile doing the Hep B viral load investigation?
That's an interesting question. It's not funded, and about 2 to 3% will be positive. However, almost all of those it's at a very low level, and almost always it's not causing hepatic inflammation and damage. I think if the ALT is normal, I wouldn't be chasing that. If the ALT is abnormal, and this is when you get into this group of heavily immunosuppressed people and everything behaves a bit differently in that setting, you would be considering it. But currently, it's not funded to be checking the viral level in that group. There's some recommendations around, but I'm yet to see someone who's actually had a really you get a positives, but it's rarely a significant positive. But if the ALT is elevated, I think it would be worth treating.
Yeah. Is there a threshold that machines can pick up?
Yeah.
Like for that last one, is it possible that there is a certain antigen positive that's so little in the serum that the machine's not?
Yeah, I think, you are correct, and I couldn't draw a cut-off or tell you what that really means, but no, you're probably, what you're really seeing in that is that it's an incredibly low level of surface antigen rather than zero surface antigen.
Is it possible to have hepatitis HBs antigen positive and antibody positive at the same time in a chronic hepatitis condition?
You mean surface antibody or?
Antibody also just start to become positive.
Generally speaking, no. Generally, one will come down before the other one comes up.
Yeah, but I have patients actually just with a long-term follow-up.
Yes.
And they start to have some antibody positive.
And the surface antigen is still positive.
Yeah.
It does happen. It happens in about 1 in 5,000 patients, or 1 in sort of 3 to 5,000 patients, that serology result. And it can occur. Well, because it's such a small group, we don't really know what that means. What it most likely means is that you've had a mutation of your virus such that the antibody that you've got doesn't exactly match with the virus that you've got. Hence, you still have surface antigen positive and antibody positive at the same time. It's really small I stuff. If you've got one patient, then you're I'm pretty sure you'll be the only person in the room. I have one patient as well who has that serology pattern. It's incredibly uncommon, but it does occur.
Yeah. If you all have a research interface,
Yeah. So look, try not to get distracted by that in terms of the overall take-home messages. If you're doing questions and exams, that's really right out one end, but it can occur. Okay, so that one that you're discussing, the surface antigen negative, surface antibody negative, so that's sort of the flip side of what you have. So it may be a false positive anti-Hep B core, that can always occur. Maybe recovering from acute Hep B infection, may have been infected in the past, and the titer of Hep B surface antibody has fallen now, which is probably the most common, and it may be undetectable level of surface antigen, as you've alluded to, and the person actually has chronic infection, occult infection, as you also alluded to there. But then that occult infection is, as I said, I've not seen it at high levels, I've only seen it at low levels. Okay, so key points. To make the diagnosis of hepatitis B, order your big 3 tests. With those pieces of information, you can determine what's happened, except if you get one in the 1 in 5,000 case. But generally speaking, you can make sense of it. And preferably don't just order hepatitis B serology, because if the lab reads your mind as you want it, you'll get the right thing, but they may not. You want to have a little break? Have a glass of water, stand up, walk around, and then we'll do some case studies.
good idea. Second dinner. Grab some more to eat. No use to do it off the computer. Yeah, I just was that. Was it the charge problem? Well, it's right now, so I might want to throw that and get a new one ordered. So let's just do that.
pain, nausea and vomiting, and he's jaundiced. The initial tests include a positive surface antigen with a positive anti-core IgM and a profoundly deranged liver function test, including an ALT of 1200. So anyone, what does this pattern suggest? Yep, acute Hep B. What are the most common ways this condition is acquired in Australia? Sex and drugs. That's it. And it depends how you're doing your rock and roll. What further action do you need to take? Yeah, so check and immunise household people. Yep. Yeah, so that sort of is part of your testing of immediate contact, so sexual partners and household contacts, and then vaccinating if they're non-immune.
I think most importantly, we need to take a sexual and the drug history first.
Yeah, exactly. Because whilst this is far and away most likely acute, there is a chance that this is a flare of chronic hepatitis B as opposed to acute, because the serology pattern with a flare of chronic hepatitis B can be basically the same as acute hepatitis B. So if this person had blood tests from 2 years ago that said they were surface antigen positive, well, this is going to represent a flare of chronic disease rather than an acute infection. As I said, most likely acute, but not absolutely. Yes, I would. So the next test for anybody who's surface antigen positive would be, viral load. Yeah, so other bloodborne viruses, HCV, HIV. Yep, A, Hep D, you can do those, yes. And you mentioned E antigen and E antibody, which is correct. We've got viral load. Other STIs would be worth screening for: chlamydia, gonorrhea, syphilis. And then depends how much you think this ALT is definitely caused by the hepatitis B, and how much you want to go looking for other causes of liver function abnormality. If it settles down over a period of weeks, then you'd be happy to call it acute hepatitis B. If there's other causes, there's a whole obviously range of other causes of significantly elevated ALT as well. So just keep that in your mind, that if the whole pattern is not fitting just with acute hepatitis B and there doesn't seem to be any risk factors, then consider other causes of what the ALT elevation might be due to. If I get an ALT of 1200, I'd like to see it repeated within a matter of days, definitely less than within a week. A small amount of people, and it's very small, and with acute hepatitis B will develop fulminant hepatic failure, and that's quoted as 0.5%. Now, I think it's actually less than that, because I can't think of a case of when that occurred in Victoria recently. I haven't spoken to the transplant unit and so forth to sort of confirm just how low that rate is. But fulminant hepatitis is a risk with acute hepatitis B. It's something in the region of 0.5% or less, but it's a risk. So yeah, I'd be definitely repeating them within a week, and so.
Another question, comment. To ensure partners being vaccinated or start vaccination, would you offer partner HBIG?
I would be extremely surprised if I found out that the partner was in fact negative. If the person has, now this person's highly likely to have an extremely high viral load and they've been sexually active for a period of time, then it's highly likely they both have the same infection. If say it's a partner who's been injecting and then they've got another partner, sorry, they've been injecting and they've got it from injecting and they've got a new partner, then that partner definitely, potentially could be given IVIG if they couldn't, whatever you said, we're not prepared to not have sex or what is not prepared to alter our risk so that we have no further risk. So that's just to take you back to your decision-making in hepatitis B algorithm. So most Hep B is due to sexual or parental transmission, as you correctly identified. Sexual and household contacts and family members of people with hepatitis B, vaccinate those who are susceptible. So really test and vaccinate, because if, this is a young guy, I think he was, I can't remember the story now, he was living with his partner and so forth. You don't know which direction this has gone. She might have been the one who had hepatitis B, other household contacts. So test first, make sure they don't have hepatitis B, and then vaccinate if appropriate.
And thinking about hepatitis, is there any role for early treatment?
There's a limited evidence around that, but no is the general.
In general practice, we'll just be monitoring their condition. If they're getting better, no need for early referral at this stage.
Yeah, correct. I think basically if you had an ALT of 1200, I'd get it repeated in a few days to less than a week. If the next one's 2,500, I'd be sending them somewhere. If the next one's less than 1,200, I'd be happy to watch it come down. Now you can draw a whole lot of scenarios around what's that first number and what would you do in each direction and so forth, and where's your cut-off threshold. But I think if it's, once you get over 1,000, you start to get concerned about the elevation of the ALT. I mean, that's a pretty significant hepatitis.
Would you see with regards to how high is the level? Like, or depending on the level, like it's more than even this, would you still send them away, or would you still check it in a few days?
Look, if it was 5,000, I'd be considering referral to emergency department, I think, because Hep B doesn't usually cause it to be, that high. You start thinking about paracetamol toxicity and, unmarked paracetamol toxicity, or have they an ischemic event, or a whole lot of other processes that if you've got a really high ALT, just sitting on it and getting a blood test tomorrow is not appropriate. Now, I guess I'm trying to think through in my head where that cut-off is and where the exact level would be. But I think once you're over 1,000, I'd be, I don't think I'd even be waiting for a week to get them back. I'd be, within a couple of days, just making sure that it's, that's at the peak and it's coming down and it's not sort of really ramping further and further up. So Alice is found to be chronically infected with hepatitis B. This is Steve's partner, I think. Their housemate is susceptible and has been advised to be vaccinated. What is the likelihood that Steve will progress to chronic infection? Yep. Less than. And when can this be determined? Yeah, so 6 months is the definition of chronic. If you've surface antigen positive separated by 6 months, you've got chronic hepatitis B. As I said, we've outlined clearly the different sorts of progression you get depending on when you acquire the hepatitis B. And this me? Yeah, diagnosis and initial management. Okay. So just to really, that story then, that case one of an acute infection with significant symptomatology plus a very elevated ALT is the rarity. Most people childhood acquisition and so forth is generally asymptomatic. People, can't necessarily identify a time when they ever had yellow eyes and so forth. Adult infection, again, you can get a significant acute hepatitis B as per that one, but often a much more mild illness, and as I said, very rarely fulminant hepatitis B. Chronic hepatitis B is generally asymptomatic. However, it leads to the problems of hepatic failure, cirrhosis, and liver cancer. They're the big concerns, and they obviously can be symptomatic. We'll discuss that.
And how about if a patient already was diagnosed for the chronic hepatitis B,
yes,
and asymptomatically just stay for several years, and then certain point they actually have abdominal pain, and the blood test shows that over 500 of the liver function tests, and then do you think it is kind of
Look, you can get flares like that in hepatitis B, which can be symptomatic, but I would like to exclude other causes of liver function abnormality in that patient as well. Now, sometimes you get a very good story, but if you've got an ALT sort of that shoots up over 500 acutely in a person with chronic hepatitis B, I'd be seriously considering other possibilities. It could be Hep B, but think about other things as well.
In that particular case, are you considering hepatitis B as an indicator for other conditions that you would straight away be testing for in terms of other bloodborne viruses or infectious diseases, STIs, or whatever?
Well, I guess anything that, so if you've got a bloodborne infection, you're at risk of the other bloodborne infections, C and HIV, so you need to be tested for those. And if you've got an STI, you need to be screened for other STIs because you're potentially at risk. Now, you might get the history from someone that they haven't been sexually active for 10 years and they use IV drugs every day, and then maybe you don't need to do the STI screening and so forth. And that's in your hands. But generally speaking, STI screening plus BBV screening when you've got a new diagnosis. A new diagnosis either acute or chronic.
And you consider that as a standard?
I would. Yeah.
Interesting. So it's not something that necessarily comes across, I guess, because the guidelines generally focus on each of the diseases in isolation. And there is some good stuff, but yeah, it doesn't come across much what people are doing in standard practice.
Yeah. And look, it comes from the history as well. If you've got a migrant who's come out here who's been in a stable relationship for years, they've come from a high prevalence country, they've never been previously tested for hepatitis B, do you really need to go checking them for gonorrhea? You probably don't. Do you need to check them for HIV and Hep C if they don't have any specific risk factors for that? Really the bloodborne viruses is you're overlapping the drug use screening into the immigrant population screening. I have an extremely low threshold to test for Hep C or HIV, but it's very, very simple, easy, quick, cheap tests that mean you can identify a potentially treatable condition. So decision making now, you probably, if you haven't seen this algorithm already, I'd be surprised, but this is really a core piece of knowledge around hepatitis B and the 4 different stages of hepatitis B, and really illustrating what the point I was making in the first couple of minutes around hepatitis B is an interaction between a virus and an immune system. So the first stage when you're exposed, well, the first stage of chronic hepatitis B, so this is decision-making chronic hepatitis B, you have a very high viral load, the liver function tests are generally speaking normal, and you're E antigen positive. And the viral loads are really high. You probably know this, but you'll get results in 100 million international units per mil. So it's incredibly high amount of virus that's circulating, but it's not stimulating the immune system. It's not driving hepatitis. The immune system, for whatever reason, is not it's recognizing that hepatitis B, but it's not actively trying to control it, and hence leading to hepatic inflammation. So you're in this immune tolerant phase. Your immune system's happy to sit there and tolerate the hepatitis B. Subsequently, your immune system, and there's, the time periods that you're in these various stages varies enormously. You can't say you'll be here for 6 months, here for 6 months. It doesn't work like that. It's sort of you progress through the stages, but not in any particular time in the particular stages. And then in immune clearance, your immune system starts to actively try and get control of the hepatitis B. As part of that, you get a flare of your LFTs. Your viral load generally comes down to some degree, and you lose, as it really comes down, you lose E antigen and you pick up E antibody, which is a marker of the level of viral replication, essentially. Now, in many cases, that will be effective. And you then go into the immune control phase. In that phase, your virus level is low, and we classically think of less than 2,000 international units per mil. So compare that to 200 million international units in the immune tolerant phase. You've got a low level of virus. Generally speaking, again, you're not getting hepatic inflammation and progression of fibrosis and so forth, and your immune system is controlling hepatitis B. And then a percentage of those people, and not everyone moves into this, in fact, the majority of people who have immune control stay in immune control lifelong. But a percentage of people who go into immune control will then, the virus, for mechanisms that are more basic science than I pretend to understand, will then escape the immune system and the level will come up, and generally speaking that the immune system at a very simplistic level tries to control the virus, and as part of that process you get hepatic inflammation occurring again. So it's in what I'll call stage 2 and 4, or immune clearance and immune escape. That's when the damage to your liver is occurring, and that's when the benefit occurs for treatment. To, in those stages, stop your viral replication, stop driving the hepatic inflammation, stop driving your fibrosis and your cirrhosis and your risk for liver cancer. So I think I'll just talk through that stage, those stages. I'll leave that.
Tom, you know a lot more about this, but I heard John Lavelle talking about that one of the reasons that's interesting in pregnancy is because it mimics, pregnant women will mimic that response quite predictably. So what this idea that you're talking about, well, when do we go into immune escape, suddenly we get an opportunity to actually follow and see what happens.
That's true. In that, I mean, pregnancy is a state of relative immunosuppression. You know, the mother is obviously relatively immunosuppressed, such that she'll tolerate having a foreign body, if you like, inside her. So you've got a relative immunosuppression, and generally speaking, hepatitis B, the viral in that stage, the viral level comes up. It's generally immune tolerant during pregnancy, but then after pregnancy, you can often get a flare in hepatitis B, in that the immune system sort of turns back on again for want of a more technical term, and you get a flare in hepatitis B as the immune system tries to control the virus, the LFTs come up and so forth. It's not uncommon to have a flare in the 6 weeks postpartum for women who have chronic hepatitis B in pregnancy. So you get an increase in your viral load in pregnancy and then an increase in your LFTs postpartum. Not that simple, but as in terms of, now again, the DNA sequencing's managed to sneak it onto that slide. You can ignore that second bit. But the viral load is important in understanding what your stages are, in following the disease through, and then when you're on treatment, in knowing whether your treatment's working or not. Now, there's a definite correlation between the incidence of cirrhosis and your viral load that is present. So having a high viral load independently is a risk factor for cirrhosis amongst a number of other risk factors. And also for the development of HCC. So the more virus you've got, potentially the more driving of your immune system you've got, the more hepatic inflammation, and it's really hepatic inflammation that's driving the HCC and the fibrosis and cirrhosis. Yes.
And what time do we need to refer patients to the specialist for?
There's not a definite answer. And hopefully one of the goals of this treatment is to alter your threshold. So at this stage, to commence treatment, someone needs to be seen by a specialist. So really in those immune escape and immune clearance phases, phase 2 and 4 on that diagram, when treatment would be seriously considered, then the person needs to be seen by a specialist to commence treatment. And there's work around having GPs continuing therapy and so forth, and not needing to go back to the specialist every 3 months to continue their therapy. But at this stage, to commence therapy, you need to go and see a specialist. My general piece of advice to GPs is that you refer patients when you don't know what to do next, or you can't do the next step because because of regulatory barriers such as specialists needing to prescribe a particular medication, and that threshold varies for lots of people. Some specialists will be saying, well, why did you refer me this patient, or why didn't you refer me this patient? I very much have an approach of, well, you make the decision. For the specialist for the GP who sees one person a year with hepatitis B because of the nature of their practice, it might be appropriate to refer all of those people because you're not confident at all. For the GP who's in a practice with a high immigrant population who's seeing 10 or 20 patients a week who have hepatitis B, then you can manage them until those stages when they would need to see a specialist. So disease progression, 5-year rates of progression, chronic hepatitis to cirrhosis, significant rates of progression, compensated to decompensated cirrhosis is something like 15%. So if you're cirrhotic, your risk of decompensation, the average time to decompensation is about 8 to 10 years, I think, for cirrhotics to decompensated. Now that depends a lot on a lot of other variables. If you stop drinking, fully control your virus, are not too fat and don't have other causes that are driving your cirrhosis, you can really even potentially reverse cirrhosis, but really stop that progression. The flip side of that is, if you drink like a fish when you're cirrhotic, you haven't got 10 years to live. 5-year survival, markers of disease progression, persistently high viral load, abnormal ALT, increase your liver cancer risk. We've talked about the increased premature mortality. So what things lead to disease progression? And there's a whole lot of host factors. Older, yeah, men, we get it again. Severity of fibrosis, recurrent flares of hepatitis, and then there's factors around the Hep B virus itself, the Hep B viral genotype and particular variants. Again, they're more research oriented for you as GPs and for me as specialists, to be perfectly honest. Unless I'm involved in a research project as such, we don't generally know what people's hepatitis B genotype is, although you can, if you have that piece of information, it does slightly affect the risk of various outcomes, but it's not something that is a day-to-day piece of it. It's not a clinical management tool we use for regularly. I'll flag one thing on the second list. On table 9, sort of down the bottom there, you've got other factors, and one of those is aflatoxin. Now, what does that mean, and why is that in any way important? We'll get to soon the screening guidelines for liver cancer and which patients should be screened for liver cancer, and you'll see that Africans with hepatitis B should be screened for liver cancer when they're more than 20 years old. That's a difficult guideline to implement from yourselves. They're not the most, without being racist, without being sort of prejudicial, some patients are much harder to get to a 10, 6-monthly follow-up than other patients, and men in their 20s are not the easiest to get to attend at. It doesn't matter what their ethnic background is, and Africans in particular struggle with that. Aflatoxins are fungal products from poorly stored corn. Lots of Africans have eaten poorly stored corn in their life in early Africa, and the average age of liver cancer in sub-Saharan Africa, particularly the southern end, is about 35. So that's where the recommendation comes out of. Now, if you're born in Tunisia in the middle class, does that really mean you should be screened from 20? I can't tell you the answer to that, but we've got a guideline. Yeah.
Another question. Are there any figures on the prevalence of co-infections with Hep C? I presume the disease progression would significantly differ.
So I don't have figures. In Australia, I think it's about 10%. Having said I don't have figures that co-infected, but that's a figure I've seen quoted, and to be perfectly honest, it doesn't reflect my practice, and I don't see very many co-infectors at all. I would say it's much lower than that, although I have seen that figure quoted. It really depends on your risk rate. If you're injecting drug user, then your risk of co-infection is very high. In fact, I would say something like 70 or 80% of people who have chronic Hep B from injecting drug use also have Hep C. If your Hep B is vertically acquired from countries with low prevalence of hepatitis C, then your risk of hepatitis C is incredibly low, and hence co-infection is very low. There is an increased risk with co-infection in terms of your progression and so forth. However, one virus tends to predominate, and that tends to be Hep C. So often when Hep C, the viral load for Hep C will be 100,000, a million, and the viral load for Hep B will be extremely low in co-infection. Again, I couldn't give you a succinct immunological explanation as to why that's the case, but generally one does predominate, and you do get a more rapid progression if you have B-C co-infection as opposed to mono-infection. You also have, if you've got HIV-B co-infection, you have a significantly more rapid progression of disease.
Thank you. I don't use genotypes myself in clinical trial settings.
Yes.
Do you see any acquired drug resistance beyond the use of Hep C?
So, yes, with the older drugs, basically. So a previous treatment with hepatitis B used to be adefovir and lamivudine. Lamivudine had very high rates of resistance development over prolonged courses, half more people would after 5 years develop resistance to lamivudine, and hence you would develop acquired resistance, and hence you would do viral resistance testing. With the newer agents, entecavir, tenofovir, the rates of resistance are extremely low. Failure generally represents failure to take your tablets as opposed to failure of your tablets to work. If you genuinely had a patient who swore black and blue that they took their tablets every day and they developed resistance on entecavir, and then their viral load flared up on entecavir or tenofovir, it would be worth doing. But I haven't seen that situation. It's documented, but it's very rare. Chronic, so key points. Yep. Chronic hepatitis B is a dynamic disease. There's no such thing as a healthy carrier. Look, I find that you can be healthy and you can have hepatitis B, but this concept of a healthy carrier has previously sort of been used to mean, right, you don't need any further follow-up, you're done, you're over in that box, you're what was probably really immune control without appreciating that you could go into immune escape. So the concept of healthy carrier, whilst you can be healthy and carry hepatitis B, it's been a concept that's meant, don't follow me up, that's it, in the past, don't have to worry about it. Patients must be regularly evaluated, and I tell all my new hepatitis B patients, you need to check, you're going to need to have a checking for your hepatitis B every 6 months from here on in. Now, occasionally they subsequently acquire surface antibody, and you can review that down the track, but I think if you keep messages simple, patients take it on much more, and a very simple message, sometimes you might need to see them more frequently than that, but you can need blood tests every 6 months, plus or minus a liver ultrasound if we're screening for liver cancer on a 6-monthly basis from here on in. Simple messages like your hepatitis B now is well under control, but we need to watch it. We need to keep an eye on it. We need to make sure that stays the situation. Yep.
And this is usually just do the alpha-fetoprotein routine for the screening?
I'll get to that, yeah. An antiviral therapy is indicated in those 2 phases. Management of patient search. If someone has been diagnosed with new hepatitis B, an initial assessment, of course, make sure that they're not informant on hepatitis. Monitoring, and this is chronic disease management. You guys are good at chronic disease management. It's what you do a lot, and hepatitis B, sometimes we don't think of it as that, but it's chronic disease management. I'll see you every 6 months and check your liver functions. We'll do a viral load every year. We'll do a liver ultrasound every 6 months. It's that sort of process. Consider referral, and as I said, I have a fairly flexible approach to referral, but for treatment you need to see a specialist. Screen household contacts and then notification. Hep B help, I flagged that once already, but it's really an excellent resource if you need help with Hep B. I speak when I have newly diagnosed people, or people have been referred to me with a new diagnosis. I talk to them about how did you get it, how can you make sure you don't give it to anyone else, and then I also make sure that I emphasise those messages around, you don't get it from sitting on a toilet seat, you don't get it from shaking someone's hand on the bus, because those messages can be very prevalent in the community and can really be detrimental to individuals. Our message should be, you need follow-up, you may need treatment, but this is something we can control. Those 15-25% figures for poor outcome with hepatitis B don't occur if we monitor you and treat you. Alcohol minimisation, it doesn't have to be absolutely zero, but definitely no more than the recommended amounts. And I tend to say to people, really look, the closer you can get to zero, the better. Try and give them adequate time to answer questions. That's always good in a busy practice. Do your best with that one. And appropriate use of interpreters. As I said, it's really important in this situation to use interpreters. Maybe you need an interpreter for me. And then translated resources where appropriate. I think, what have we done? So we've had a bit of a discussion through initial testing. Most people would recommend that you do a liver ultrasound as part of your initial assessment of someone with newly diagnosed hepatitis B. It's not an absolute definite, but I think most people would do that. Once you move to the criteria for liver cancer screening, then you need to be doing regular ultrasounds at that point. you've got your algorithms. So monitoring of patients, regular review, I think that's a really key message. Frequency determined by various things. I say 6 monthly, keep it simple. You need liver function tests every 6 months. In a perfect world, I'd like viral loads potentially to be more frequently than yearly, but Medicare only funds a yearly viral load for patients. So if you're on treatment, you can have a viral load 4 times a year, but if you're not on treatment, you can only have it once. So it is a bit of a restriction, and you'll probably see that patients who are managed in public hospitals may well get their viral loads done twice a year because they're not subject to those restrictions around testing. But you know, that's the funding requirement. Now, for liver cancer screening, and we'll get to the who needs liver cancer screening, you need to have the guideline is that you need to have an ultrasound every 6 months, plus or minus an alpha-fetoprotein, and that reflects the American Association for the Study of Liver Disease has dropped the alpha-fetoprotein from the liver cancer screening guidelines now, suggesting that the additional incremental benefit of adding the alpha-fetoprotein to the ultrasound is minimal. One of the others, I think it's the European Society, hasn't yet dropped it, so it's still there. Australia, like in most of these things, sort of sits a little bit in the middle. And you'll get both pieces of recommendations. But I think over time we'll move to dropping the alpha-fetoprotein because the amount of additional benefit that it adds to an ultrasound, and I think part of that reflects that we've got much better quality ultrasounds now, so the additional incremental benefit is not as great that it adds. It's not wrong to do alpha-fetoprotein every 6 months along with your liver cancer, with your liver ultrasound. It is wrong not to do the liver ultrasound, however.
Someone just asked questions, fibre scanning useful?
So FibroScan is an excellent test for identifying the stage of fibrosis. It does not identify lesions in the liver, so it does not pick up liver cancer. So it's not a useful test for identifying liver cancer. And then just to flag, if someone does have cirrhosis, and there's a whole other set of guidelines around how to manage cirrhotic patients and so forth. So gastroscopes to assure varices and banding of varices, as well as your screening for liver cancer, but you've also got other management of cirrhosis. And yeah, can't emphasise too much, all Hep B surface antigen positive patients should be assessed at baseline and at regular intervals. It's chronic disease management. How often do you monitor? So immune tolerance sort of every 3 to 6 months, immune control every 6 to 12 months. I think most people will be monitoring every 6 months. Immune clearance, you know, they require treatment therapy. Once people are stable on therapy, you might only, even I've got some people who are stable on therapy, I only see them every 6 months. But generally speaking, when you commence therapy, you might see them at 8 weeks and then spread it out to 3 monthly. And if they're stable over a year or so, then you might spread it out to 6 monthly. But generally speaking, you know, 2 to 3 months, 3 monthly on treatment initially. That's just a little fact there about alluding to the fact you can only get one viral load if you're not on treatment. You can sort of sneak around it if you put patient to commence treatment. No time frame mentioned. So if you put that in your clinical notes, if you really need an extra Hep B viral load and the patient's not prepared to pay for it and you think it's going to change the management, you can get out of that. So surveillance for liver cancer is recommended for patients with chronic hepatitis B who meet the criteria below. And that's that 6 monthly liver ultrasound plus or minus the alpha-fetoprotein, depending on whose guidelines you give the greatest weight. All patients with cirrhosis, and I should actually put this in for your general hats, that's all patients with cirrhosis. Doesn't matter whether it's caused by Hep B, doesn't matter whether it's caused by alcohol or whatever. The only people you wouldn't screen is someone who's got decompensated liver disease, so if you found something, you wouldn't do it anyway. You know, who's so far down the track of decompensation that if you found a liver lesion, well, you know, they're going to be down a palliative pathway anyway. There's no point screening those patients. But anyone with cirrhosis for any cause should be screened for liver cancer, Hep B in particular. Patients with a family history of liver cancer, Asian males over 40, Asian females over 50. And for simplicity, I use the broadest possible definition of Asia. Anywhere from the Bering Sea, which I think is between Alaska and the US, through to Israel and Saudi Arabia, any sort of the broadest definition of Asia, Asian males over 40, Asian females over 50, and Africans over 20. As I said, because of this aflatoxin exposure risk, and partly because of the actual genotype of hepatitis B, Africans are at much greater risk of getting liver cancer and getting it younger. Aboriginal and Torres Strait Islander people. Now, there's a question mark next to that because it's one of those guidelines that, there's never been a trial of HCC screening in Aboriginal populations to definitely show that it's got clinical benefit. We're extrapolating from trials in other ethnic populations who have high rates of hepatitis B that have shown benefit, but I think everyone would recommend that screening.
Aboriginal people.
Yeah, good question. Good question. Again, this aflatoxin, I think most people would be saying cirrhotics, men over 40, women over 50, and not the sort of down to 20 regions. But it's not an absolutely strictly evidence-based, it's a sort of extrapolating thing. And I have to say, I tend to say males over 40, females over 50. You get the same question, what do you do with a Greek lady who's 55? I mean, do you screen her for liver cancer? There's no guideline around that. I tend to say, the fact that I just say males over 40 or females over 50, is that correct? Well, there's an absence of a guideline. So there's no evidence. Now, who needs consideration of treatment? So if you're e-antigen positive, if your viral load's over 20,000, and if you're e-antigen negative and your viral load's over 2,000, and you've got evidence of hepatic damage, and that can be elevated ALT, it can be a fibrosis score on a fibrous scan that's elevated, it can be a biopsy that show that you've got elevations in your liver function. So some evidence that you both have virus and that virus is driving your immune system and causing damage. Basically, and they're the levels of virus, plus you need that virus to be driving your immune system, causing damage. And other considerations, I think anyone with Hep B and cirrhosis should be treated. It doesn't matter if your viral load's 50, you should be treated in that setting. And then there's specific circumstances like during pregnancy where you're treating for the risk of transmission rather than for the mother per se. The goal of antiviral treatment is to limit liver damage, to reduce the virus, hence reduce the inflammation, reduce your risk of liver cancer, eradicate hepatitis B infection. So rarely people do develop surface antibody on treatment. Now they develop it on treatment much more frequently than off treatment, but still it's rare to develop surface antibody. So most people who you commence therapy, you need to say you'll be on this long term. And improve survival, which has been clearly shown. I think we've talked a fair bit about the fact that this population is largely from ethnically diverse populations, and hence it needs to be aware of stigma and health issues and different health perceptions, different norms around discussions of sexuality. Not that you necessarily have all of those right answers, but I think if you're cognizant that the population you're dealing with often has a different set of norms to what you do, it will lead to less issues. I think that sort of has gone through there. And as I said, all patients with Hep B need monitoring lifelong, including management of your liver, assess the virus, assess is it causing liver damage, and assess is the person at risk of cancer and developing cancer. All right, we're getting there. I think we're nearly there. So Chen's a 28-year-old student who presents following a recent trip to China to attend the funeral of his father who died of a liver tumour. He's attending your practice. He's had an apparent upper respiratory tract infection whilst overseas. I hope he hasn't got one of those flus. He's come back from China. Anyway, sorry, that's a side issue. What concerns does Chen's family history raise? Absolutely correct. Enhanced HCC, enhanced death. How would you discuss these concerns with Chen? I mean, I think the key test is to raise the possibility that he needs to be screened. exactly how you discuss that depending on your interaction with the patient. But I think the key thing is that this patient needs to not leave your room today without a blood test form to be getting tested for hepatitis B. What tests would you order to address these concerns? Or anybody? Any other tests you might order in this, gentleman? Yeah, the question is, would you do a liver ultrasound just per se, given his father's recently died of liver cancer? Now, probably you could do the hepatitis B testing. If he doesn't have Hep B, then his risk of liver cancer is, assuming all other things are normal, he's healthy and doesn't have any other concerns, is very low. But just to sort of think a bit broadly, I think I'd be testing this guy for Hep C as well. These investigations do not just order Hep B serology. I think you might have seen that slide earlier. Maybe once or twice, sorry. So Chen's Hep B serology shows surface antigen that's positive, surface antibody is negative, and core antibody positive. What does this mean? Well, yeah, as a standalone, we don't know whether it's chronic and acute at this point. It indicates that he has Hep B. We'd need to have some sort of time evidence there to clearly say it's chronic, but the whole history points to being chronic. What further tests would you order? Yeah, E antibody, viral load. Yep. Liver ultrasound. Hep A probably, because it'd be good to have him vaccinated against Hep A. Hep D is worth testing as well for co-infection, although it doesn't necessarily change your management immediately. It's worthwhile down the track. Liver function test, of course. Yeah.
Another question. Where could you refer overseas students who can't afford to follow through with their chronic Hep B?
Good question. The rules for overseas students are that they have to have medical insurance. Now, most people have taken out the minimum, most no-frills insurance that they possibly can, and hence it may not cover hepatitis B because it may be considered a chronic condition. So there's not, there's not a free place that I'm aware of. The honest truth is some people go back to China, and the public hospitals, if someone's genuinely sick, will treat and sort of seek a bill later. But there's not an answer that I'm aware of to that question.
Generally, if I work in a clinic with a large number of patients, generally if the hepatitis B was diagnosed before they arrived to Australia, insurance won't cover it. But you get liver function test done. If you diagnose them in Australia and it wasn't declared, generally the insurance covers at least tested.
Yep. And look, if the treatment, if someone was warranting treatment, it's not actually ridiculous to go back to China and get it, because the drug quality is actually pretty good on the whole, and it does cost $3,000 or $4,000 a year for treatment if you don't have a card of any sort. Initial assessment, I think we've talked a bit about the various tests you might want to do. We've talked about liver cancer screening. So he's an Asian male who he wasn't 40, was he? No, so he doesn't need liver cancer screening, but he's got a family history, and I think he's got a family history that's strongly suggestive that it's HCC, so he would need screening. So he comes back, he's E antigen positive and E antibody negative. He's got a very high viral load, 10 million international units. His ALT is elevated, and 3 months later, it's still elevated. What are you going to do? Which phase is he in?
Is there another cause of the ALT?
Excellent question. Excellent question. Yeah. Assuming you've sort of done your screening for any other causes of liver function abnormality, and that's all come back negative. Yeah, that's right. Sort of immune clear. It's still pretty low ALTs, but elevated, and some labs still quote old reference ranges for ALTs. Normal being 50, 55. That's not normal for ALT, and they've done studies where if you take out all the drinkers and all the fat people, and then you'd really look at normal ALT. Those values of ALT of 30 for men and ALT of 19 for women are the values when you take out all the people who. So there's been a real shift downwards in what's actually a normal ALT, as opposed to a bell curve ALT where we say this 2.5%, if you're above that, that's abnormal. But let's not really look at physiologically what's normal. It's much lower than that. What is your interpretation of these results? I think, what do you recommend? Likely to be immune clearance phase, ALT is elevated, should be considered for antiviral therapy, particularly given the family history of suspected HCC. Chen gets seen by a hepatologist. I don't know why he wasn't seen by an ID physician, but anyway. Has a liver biopsy, which shows moderate necroinflammatory and fibrosis activity. Just to highlight a point, up until 2 years ago, a bit over, in order to start Hep B treatment, you needed to have a liver biopsy. That's no longer a requirement. So if you assess someone that they need to have treatment, they can go on to treatment. And most people wouldn't get a liver biopsy. To be honest, I wouldn't have biopsied this guy. You've seen three monthly for LFT and HB virus monitoring. By 48 weeks, his ALT is normalised, his Hep B is undetectable, his E antigen is still positive, and he remains on treatment. Aims of treatment, I think we've talked about that. So Sandra's a 45-year-old woman living in the regional centre. She's Indigenous. She works part-time, married with 2 kids, lives at home, smokes 15 cigarettes a day, doesn't drink alcohol. Her BMI is a little bit on the high side, known to have impaired glucose tolerance, but is otherwise well. Her daughter was recently diagnosed with HBV on antenatal screening. So this is she's a grandmother, or she's about to become a grandmother. Is Sandra at risk of infection from her daughter? Correct. Yeah, correct answer. In all likelihood, the daughter has got it from Sandra. So, that's not absolute. There's injecting drug use, there's other risk factors and so forth that could mean that's not the case. And Sandra at 45 would not have routinely been vaccinated, so she may be non-immune. Should Sandra be vaccinated?
Sorry, Tom, I just missed the question back to Chen.
Yeah.
Says Chen is a medical student. What are his limitations to practice or register?
Yeah, so Chen, if he has a fully suppressed virus on therapy, he doesn't have too many limitations. Now, I'll take that as a question on notice because I'd have to check for Hep B on treatment what his restrictions around bloodborne doing exposure-prone procedures are. I couldn't give you that answer. It is in an influx in terms of that, but I couldn't say whether or not he can do exposure-prone procedures. He can definitely continue as a doctor if he's fully suppressed, but whether or not he can do exposure-prone procedures, I'm not sure.
I'll try and get you an answer by Sunday.
Yeah, so if you can see, hit Ben up and see what answer he gives to that one. We know that Indigenous Australians are a priority population. So Sandra gets tested. She's surface antigen positive, core antibody positive. She's a bit bewildered as to what's going on. She says, "I've never injected drugs." We know that. How can she tell Sandra about how she probably acquired hepatitis B? Well, she might have acquired it from her mother. So just to sort of illustrate the multi-generational nature of things. It's been screening in the process of her grandchild being conceived, or her grandchild's antenatal care, and now she may well have got it from her mother, so the great-grandmother of the person who was actually screened to protect. Injection at birth. Initial assessment, I think we've talked a fair bit about initial assessment. So Sandra has an ALT that's elevated for a woman, just slightly. She's E antigen negative and E antibody positive. She has testing for other causes or other bloodborne viruses and causes that's non-contributory. Her viral load's just a bit elevated. We sort of said 2,000's the number. It's 2.5. She's got an ALT of 28. She's got an ultrasound that's consistent with fatty liver. You're going to treat her?
Two other causes for elevated ALT. She's diabetic.
Yes.
Could you monitor her for a while?
I think that would be pretty reasonable to monitor, or to try and get a biopsy or some extra additional information. So she's seen by a hepatitis specialist who recommends a biopsy. It was very difficult because the nearest facility was hours away. 4 months later she got there. The results show an F4 fibrosis. So F4 essentially indicating cirrhosis, or being equivalent to cirrhosis, with 5% steatosis. So I guess by saying that you're saying, well, this is not just fatty liver, we're saying it's a small percentage of steatosis. Would Sandra benefit from antiretroviral therapy? And I think that's going to tip you over, isn't it? You're thinking she's got those just over markers on but she now has cirrhosis. So now anyone with cirrhosis with Hep B, I'd basically treat. I think I don't want any virus in the blood if I can have it for someone who's got cirrhosis and Hep B. Hep A vaccination, in an Indigenous lady who's 45, I'd definitely check her Hep A to see whether she's been exposed. Probably pretty high risk that she's actually been exposed as a young kid and doesn't need vaccination. But if she's not been exposed and is IgG negative, she needs vaccination for Hep A.
And would that be covered?
In an Indigenous person, I think it is, yes. Yep. In the general population, Hep A is not, but in Indigenous people it is. Surveillance is recommended. As we said, the Aboriginal and Torres Strait Island people is extrapolating from other evidence, but all patients with cirrhosis, number one, so she gets it from that, independent of her ethnicity. Who needs treatment? We've talked about elevated virus plus evidence of elevated or hepatic irritation, hepatic inflammation. And then we talked about that. How are we going? How are we going for time? This is the last one.
A couple of minutes, 4 minutes.
All right. So, Kajar is a 48-year-old gent from Burma, arrived in Australia 2 weeks ago as a refugee, along with his wife and 3 kids. Doesn't speak much English. He's generally healthy and no medication. As part of his post-biomedical assessment, he's found to have his surface antigen positive, core antibody positive, antibody to Hep B surface negative, and his Hep B E antibody positive and Hep B E antigen negative. So we know what stage, well, we don't know what stage he's in, but what 2 possible stages could he be in? Immune control or immune escape. How do you interpret these blood results? You've just done that. How is Kajar likely to have contracted his HBV? Yeah, childhood vertically. Just amongst the Burmese population, there's a bit of IV drug use amongst that population as well, sort of the Burmese triangle. What's the sort of Cambodia, Burma triangle where there's a bit of, it's not zero. It's generally speaking vertical, you're absolutely correct. But what test would you request? I think we've talked about that. How do you assess if an interpreter is needed to work with him? That's right. And just to really reiterate that point around family members are, I know it's more convenient. I know when you've got someone sitting there, it's just easy to ask them to interpret, but that's really not acceptable, particularly when you're doing STIs.
How pushy would you get if the patient declines an interpreter or feels that English is adequate?
The way I've got around that is if someone, I say, look, well, let's see how we go. And then sometimes you sort of, pretty quickly it becomes apparent that it is adequate, or, look, I think your English is great for day-to-day things, but this is a complex matter. I think we'll just get an interpreter for this if that's okay. Use it one way. And you can occasionally get the emphatic interpreter. Now, I often ask, do they want the interpreter to be confidential? Because for TIS, you don't need to give a name. You can just say confidential. And you can also ask for an interstate interpreter, which is something which I do with some HIV patients. So, because it's a small ethnic community, they know everyone in Victoria in that ethnic community, or maybe they don't, but there's a perception that you could run into anyone in that ethnic community in Victoria. You can ask for an interstate interpreter. Now, that might take them a bit longer to get and so forth, but you can do that.
Can I just ask a question about symptoms?
Yes.
I thought you said when actually the E antigen negative and the levels, the hepatitis B DNA more than 2,000, you consider treatment. So
Yes.
You don't really monitor, you think of treating, no?
Yes.
Regardless of what the ART is.
You do.
Monitoring it, and we just said that you have to treat.
I guess by consider treatment, I think your colleague's point here being that ALT, if you're convinced that that ALT elevation is due to the hepatitis B, then treat. If that ALT elevation you think is due to fatty liver, then what you're going to find is that you treat and the ALT stands at exactly the same level because it's not the Hep B that's driving it. Now, obviously that's sort of a theoretical approach to the issue, but that's really what you're trying to delineate. If you then move to doing an assessment of fibrosis and you see that the person's have fibrosis, then you might say all bets are off. I think that I'm not going to be academic about what I think is causing that ALT rise. I'm just going to treat this person because it's clear that whatever it is causing damage, and we want to do everything that we can do to reverse all the possible causes of damage. And you might well find that with that previous patient, you do put them on treatment, and their ALT stays at 28. The virus comes down to undetectable, the ALT stays at 28. You know, maybe the fatty liver is contributing to things, but you would still treat. Does that clarify that?
Tom, I'm just looking at the national guidelines for the management of healthcare workers known to be infected with bloodborne viruses.
Oh, great, thanks.
And for step this answer through the webinar as well, so people should be able to read that there. Specific to HPV, so healthcare workers must not perform exposure-prone procedures while they are HPV DNA positive, but may be permitted to return following spontaneous clearing of HPV DNA or clearing of HPV DNA in response to treatment.
Yeah, no, so you can perform exposure-prone procedures. What I thought I'm pleased to hear that. We've talked about the stages, we've talked about initial assessment. At Kajar's follow-up, he's very upset. He thinks that he's going to die from his liver problems. His liver edge is palpable but smooth. His weight's okay. He's not. His BMI is not high. He doesn't drink much alcohol. But his ALTs are 86. He's E antigen negative, but his viral load's 120,000. His LFTs are otherwise normal. He's had screening for other causes of liver function abnormality, and that's negative. Just of note, schistosomiasis serology is also negative. One of the causes in particularly African populations of hepatic damage is schistosomiasis, so it can be worth screening those populations for schistosomiasis as well. Africans and Southeast Asians, particularly sort of Cambodia, Burma, not so much China and Vietnam places, but Cambodia, Burma in particular, Laos. What are the complications of Hep B? We know what's the risk of dying from untreated hepatitis B. We've been through that. If Paul's wife had contracted hepatitis B from his recently through sexual transmission, what would her risk of developing chronic hepatitis B be? 5%. She won't have contracted hepatitis B recently from Jaw. They've got 2 kids and they've been married for 20 years or something. So her period of risk from Jaw was 20 years ago. You know, by now she either has it or she doesn't have it. She's either developed immunity from either vaccination or being exposed, or she has chronic disease herself. She will not be at risk of getting it when he goes home tonight. Differences, we've talked about that. He's worried about telling his wife about his status. She will not want to eat with him or share the bathroom with him. You know, we've talked about the importance of explaining those things. I mentioned again, you mentioned that you have to notify the public health authorities again to just reinforce that you need to say that this is something you have to do. The public health authorities don't chase you. And the most important thing to let people know is that it doesn't affect your immigration papers and status. If you come here as a refugee, you've been accepted as a refugee. You can stay here as a refugee. You've been accepted, that's it. The fact that you've got hepatitis B doesn't affect that. You ask about the liver cancer history. He says he doesn't know. Should he be screened for liver cancer? Yeah, he's an Asian male over 40, so he's screened on that criteria alone. Whether or not he had a family history is sort of academic and probably increases your risk, but it doesn't affect whether or not you should screen him. There you go. I ran slightly over there. I thought I was going to run over.
Well in there. Thank you very much. And anyone got any more questions?
So he would be a candidate for treatment.
Yeah, that sort of actually actually didn't really end up on a slide there, but he would almost certainly go on to treatment. I would see very little reason not to treat him. So in fact, I can't see why I wouldn't. The only reason I wouldn't treat him is he said, I'm flat out not going to take the treatment or something like that. So.
Great. Thanks, everyone, and see you on Sunday morning. Can you just make sure, if you haven't signed, just sign in so I know who hasn't. The ones who are on webinar, I've got a record of you, so you don't have to worry. We'll see everyone 8:30 on Sunday. Thank you.
Thank you.
Judy Lamb said I hope you feel better soon.
Sorry?
Judy Lamb said I hope you feel better.
Yeah, I don't feel, I just got a running nose.